Hello, dear students. Today we have the 6th lecture in the cycle of traumatology, orthopedics. The lecture is devoted to a fairly modern, topical disease. The disease, which, of course, has an indirect relation to traumatology and orthopedics as well. To a greater extent, this disease is treated by therapists, general practitioners, endocrinologists, and sometimes gynecologists. But the consequences of this disease fall on the shoulders of orthopedic traumatologists, and this disease is called osteoporosis. So, what is osteoporosis? Osteoporosis is sometimes called the silent epidemic of the 21st century. Here is a comparison or an epithet. So, osteoporosis is a metabolic bone disease, defined as a generalized loss of bone mass per unit volume, exceeding the passionate and sexual norms. That is, normally, with all the desire, with age, bone density, of course, changes and decreases. So, osteoporosis is accompanied by a violation of the microarchitectonics of bone tissue, which leads to a decrease in the physical strength of the bone and, as a result, to a high risk of fractures or deformities of bones. And in this case, with osteoporosis, the mechanical effort required to break the bone is significantly less than it would be required if the bone were normal. It is possible, in principle, to say that osteoporosis is the cause of pathological fractures, if we regard osteoporosis as a serious systemic metabolic disorder that leads just really to a violation of the density and strength of our bones. As such, the disease, on the one hand, has only recently appeared in the spectrum of our clinical knowledge, but in fact, information about it has been known for a long time, and the first description of osteoporosis was made back in its time, in 1873, by doctors such as Charcot and Vulpian. In the 1824th year, British Dr. Ashley Cooper already pointed out that he notes the fragility of bones when studying the clinic of senile hip fractures. There were also hip neck fractures in the elderly. Osteoporosis becomes a disease known by a clinician thanks to the works of an American scientist, the founder of classical clinical histology Fuller Albright in the very near 1934 year. He described the processes of bone resorption formation, as well as changes in this very disease, in osteoporosis. So, let's remember the histology a little bit. What is a bone? Bone is a highly specific tissue consisting of a bone matrix. This is from a mineral component, mainly represented by calcium salts, and from living bone cells. Moreover, the bone has a rather specific geometric structure. That is, we have a compact bone substance that is quite dense and strong. There is a spongy bone substance. A compact bone substance, when viewed under a microscope, has a heavy shape, and the same elongated in one particular direction, which implies a sufficiently strong structure, which is presented, if you remember the children's fairy tale about Grigarash, that you can break a stick, but you can break one twig too, and it is quite difficult to break a whole bundle of twigs. Also here, a lot of tubular structures elongated in one direction presupposes a sufficiently large strength. Of course, we definitely have a large margin of safety here because this is not a soft tissue structure, but a fairly dense formation, which is based again, as we said, on the mineral component of calcium salts. So, with age, natural aging occurs in the body, of course. Both the biochemistry and the histological structure of bone tissue change. Sometimes these changes may, say, be not physiologically due to age, but occur against the background of a disease called osteoporosis. In this case, we are rapidly losing a mineral component from some volume of bone matter. Currently, according to WHO, osteoporosis ranks fourth among non-communicable diseases after diseases of the cardiovascular system, after oncopathology, and after diabetes mellitus. And the purity of fractures associated with osteoporosis all over the world clearly tends to increase. That is, if we take statistics for our country, then every third woman and every fifth man in this case, at retirement age, over the age of 55 suffer from osteoporosis. And the most dangerous thing in this case is that fractures may occur as a result of this very disease. Well, pay attention, there is an illustration and a picture on the left that the costa tissue in our patients with osteoporosis is beginning to change. That is, the trabecular structure begins to assume the situation that the cells become larger. As a result, we have a decrease in bone strength. Osteoporosis can be the cause of fractures of any localization, but the most characteristic fractures of the following sections are the maximum femur, especially the medial fracture of the maximum femur, and, in particular, these are fractures of the femoral neck. These are fractures of the vertebral body, which are mainly of a compression nature, and quite often these people, having brought such fractures, are not always visually noticeable fractures. They change, their posture changes. If you remember the advertisement for the chondroxide cream, where crooked people were spoken and so on. That is, this is just the moment of increasing thoracic kyphosis with age, when grandmothers become so twisted, just the same manifestation in the form of pathological fractures of the vertebral bodies of a compression nature. The next marker fracture. Such fractures in osteoporosis are called marker. This refers to a fracture of the beam in a typical place. This is a fracture of the distal metaepiphysis of the radius. Sometimes marker fractures associated with the presence of osteoporosis include a fracture of the neck of the shoulder. Some authors include it, some, as it were, do not focus much on it, but a fracture of the neck of the humerus can also be regarded as one of the markers of osteoporosis. Keep in mind, you need to understand perfectly well that these fractures can quite easily occur without osteoporosis at all. But if we take such a science as medical statistics, then the figures of such fractures in people with osteoporosis clearly tell us that these people have a much higher purity of occurrence of these fractures than people who do not have osteoporosis. There are many examples. Let's say the risk of hip fractures throughout life in white women is 15%, in men 5%, but the fact that we can even assume that in this case, that osteoporosis is a disease of the white race, that is, Caucasians, and, as we have already told, it occurs more often in women. The medical and social significance of the problem is also due to the fact that a hip fracture in 20% of cases becomes the cause of death. Not directly the fracture itself, but those consequences that lead to impaired motor activity of the patient, and as a consequence to stagnation in pulmonary activity, to the development of hypostatic pneumonia, to variants of impaired, let's say, motor activity, which lead to the risk of thrombosis, to pulmonary artery thromboembolism, and to the death of patients. And 50% of patients who have broken the hip neck, who suffer from osteoporosis in old age, later become disabled and, as a result, need expensive rehabilitation measures, expensive supportive treatment, or corrective endoprosthetics. And as a social problem for the state, it is probably much easier for society to prevent these types of pathology than to treat them later. Pathogenesis of osteoporosis. Osteoporosis is a multifactorial disease. Its nature is still not completely clear, but there are a huge number of statistically confirmed factors that can accompany the patient and lead to the development of osteoporosis. The main emphasis is on genetic predisposition, that is, based on family analysis. Well, the situation is quite clearly traced that the presence of hip fractures in relatives may indicate that in this case, the patient himself may also have osteoporosis with age and as a consequence of the risks of hip fracture. The smoking variant, especially in menopausal women, is clearly associated with the development of subsequent osteoporosis. A fragile physique, a body mass index of less than 23, or a decrease in body weight by more than 10%, yes, after a disease. It can lead to the development of osteoporosis quite quickly in the future. Excessive alcohol consumption. Here are the figures. I don't know how reliable they are, but the daily consumption of more than 20 milliliters of strong alcohol, 100 milliliters of wine or 300 milliliters of beer per day can contribute to the development of osteoporosis, especially more, let's say. The phrase about beer sounds plausible here. Yes, the peculiarity of beer, as you remember, is that it has gas bubbles, and in this case it may be due to the leaching of calcium from the body. Excessive consumption of caffeine is also associated with the subsequent development of osteoporosis. I have already told you about such a genetic feature as our race with you, that is, the Caucasian race with light skin, which has little enough opportunity to form, let's say, vitamin D with skin poor in melanin with you and me in melatonin, more precisely. Yes, our skin, light skin, the Caucasian race is predisposing factor to osteoporosis. Early menopause in women, including surgical menopause after undergoing operations on a woman's reproductive system, can lead to osteoporosis. Sedentary lifestyle, what we call hypodynamia. A decrease in physical activity in most cases recently, this is rare and occurs nearby, may be the cause of the development of osteoporosis. Iatrogenia, that is, taking a number of drugs, sometimes a reasonable intake, because in this case it is necessary to treat serious diseases with these drugs, can lead to the development of osteoporosis. These are drugs such as steroid-type hormonal drugs, corticosteroids. These are drugs that affect the function of the thyroid gland. These are levothyroxine, anticonvulsants, heparin. These drugs in their systemic intake can constantly lead to the development of osteoporosis. Conditions associated with the increased need of the body for calcium salts, pregnancy, breastfeeding, as well as a number of chronic systemic diseases, such as rheumatoid arthritis, sarcoidosis, cirrhosis of the liver, leukemia, diabetes mellitus, vibration disease, all this can lead to osteoporosis. A prolonged state of forced restriction of muscle activity. Well, for example, prolonged immobilization associated with injuries or orthopedic pathology and its treatment can lead to the development of local osteoporosis. Well, the moment of stress, as a universal, let's say, measure of various diseases, too, has not been cancelled. Persistent chronic stressful situations can lead to osteoporosis. Age, as we have already said, it all started with this in 1824th year, and the main dependence of the appearance of this disease was precisely associated with age. Yes, indeed, the more regretful, the older a person is, the more often and more we notice a violation of bone mineral density in him. Osteoporosis is often characterized by an asymptomatic course in the first 10 to 15 years, and this is the insidiousness of this disease. Yes, complaints are possible, complaints of pain in the bones, especially in the lumbar, thoracic spine, which can mimic a completely natural disease for a degenerative nature, also mainly appearing with age, is osteochondrosis. A slow decrease in the patient's growth, a change in his posture towards an increase in thoracic kyphosis. Restriction of motor activity, loss of body weight. These are some of the main manifestations of osteoporosis that can be visually noticed. Often, examinations begin after the accidental detection of a fracture, especially a fracture of the vertebrae. This is of course very bad. That is, in this case, we do not keep up with the development of the disease. There is no opportunity to engage in prevention and its prevention. Primary and secondary osteoporosis are distinguished. If osteoporosis is the result of the underlying disease, then they talk about secondary osteoporosis. If we have an idiopathic system of origin and mainly associate, yes, with age characteristics, with the peculiarities of genetics, then it is customary to talk about primary osteoporosis. The role of an orthopedic traumatologist, as in identifying patients with osteoporosis, is quite unique in this case, since he is often the only doctor who leads a patient with a fracture. He is the first to touch, his bone tissue, and in view of this, the orthopedist should make every effort to find out whether the fracture is actually a consequence of insufficient bone quality, which makes the prevention of future fractures in demand. Yes, that is, an orthopedic traumatologist, having certain predisposing factors in the patient, should think about assessing the mineral density of this patient, especially if we are faced with exactly the same marker fractures that several slides talked about. What can be found? Yes, that is, look at the instrumental diagnosis of our musculoskeletal system, performed using radiography. The experienced eye of an orthopedic traumatologist, the experienced eye of a radiologist may suspect a decrease in bone mineral density. Here, pay attention, the brush presented on the left and bottom, we see clear areas of darkening, that is, a decrease in bone density in the epiphyseal areas of the brush, the bones of the brush. We see the same thing here. Yes, in the area of the proximal meta of the epiphysis there is more of the tibia in the picture on the top right. Well, micro-preparations are presented here, what a bone with a normal trabecular structure looks like, what a bone affected by osteoporosis may look like, respectively. There are a number of aspects here. Just like that, rushing madly and looking at the pictures probably won't work. In this case, we need not just the experience of a doctor, but the experience that accompanies working with this X-ray machine. Yes, it is with this X-ray technician. You know, people are different and the equipment does not always perform exactly the same pictures here. Each device has its own specific features, and even each laboratory assistant carries out diagnostic measures, even if he sets seemingly similar parameters on the device. All the same, with all the desire, somehow they still have these moments. That is, for a long time, taking pictures on the same device, having, say, at a glance, in this case, sometimes it begins to be seen and understood that this person has a fracture, but the normal structure of the bone substance, this person has it sparse. A more accurate diagnostic method that allows you to clearly determine the bone mineral density in the parameters, and sometimes not just in qualitative, but in quantitative parameters, is the so-called densitometry. You may not have heard the name of such a method before today's lecture. That is, densitometry is a method for determining bone mineral density. This is the most objective, reliable method of early diagnosis of osteoporosis. Densitometry can be ultrasound, less accurate, but without harmful, without side effects and inexpensive, cheap and ultrasonic bone densitometry. In essence, it is a very simple and uncomplicated screening method that can be applied to almost any age group of the population in its entirety as a medical examination. And an even more reliable method is 1 and 2 phaton X-ray absorptiometry, that is, sometimes it is simply called the simpler word X-ray densitometry. In this case, this technique has, of course, its side effects. It is ionizing X-ray radiation, but at the same time it is a much more accurate technique that allows us to more accurately diagnose our violation of bone mineral density. At the output of densitometry, we get an indicator called the T criterion. So, normally, the T criterion of bone mineral density is from +25 to 1 SD. This is a sound digital, that is, the unit measuring bone mineral density from +25 to -1. In the case of a further decrease in the T criterion from -1 to -2.5, it is customary to talk about a predisposition to osteoporosis, about a borderline condition called osteopenia, and with a decrease in those criteria of less than 2.5 SD, we are talking clearly about a violation of mineral density, about osteoporosis. That is, bone mineral density is determined by a guideline in assessing the risk of fractures, which is why traumatologists work with such indicators in the aspect of fracture prevention. It should be borne in mind that no one has cancelled other risks for fractures. In all desire, a person, even with good indications of bone mineral density, can very calmly, having been injured, break a limb. So, normal bone mineral density does not exclude the possibility of fractures in any way, but reduced bone mineral density suggests that fractures are very possible, and at moments of injury that would not normally lead to a bone fracture, they become inevitable. That is, just a fall, which, with the usual quality of the bone, a person would simply have suffered, got up, walked on, perhaps would have felt the phenomenon of the injury surface in the form of a bruise, which in this case lead to serious fractures. So, what kind of indications can there be for an examination, a simple examination called densitometry? In this case, probably, these slides are more required by general practitioners, therapists, in some cases by a district obstetrician gynecologist, or rather just a polyclinic gynecologist. So, what do we have? Menopause, which occurred in a woman before the age of 45 for examination of bone mineral density. Taking corticosteroids for longer than 3 months in doses of more than 7.5 milligrams per day. A long period of immobility of more than 6 months. This is mainly neurology, orthopedics, traumatology. Secondary osteoporosis, which may be caused by the presence of diseases such as anorexia nervosa, hyperthyroidism, hyperparathyroidism, hypogonadism. We noticed a set of endocrine diseases, well, except for the first ones, which are more related to psychiatry. Type I diabetes mellitus, Itsenko-Cushing's disease, malabsorption syndrome, chronic liver diseases, hepatic insufficiency with rheumatoid arthritis. There is a very large range of different specialists who treat different diseases, but they should, in theory, think about the fact that the patient may have another disease, which in the future may lead to injuries. Secondary menorrhea, excluding pregnancy. Well, if we take a general practitioner, who is now a family doctor, it is customary to say that osteoporosis in close relatives. A less important risk factor. In this case, the indication for the examination is not one of the factors, but a combination of several. Excessive smoking, excessive alcohol consumption, a fragile physique, a woman who has not given birth, who is already at the end of her fertile function, that is, an adult woman who has passed the age when gynecologists begin to call them later giving birth, yes, that is, a woman who has not given birth. Low physical activity in the patient, insufficient intake of calcium with food, especially if the characters are engaged in some kind of diets, these are all kinds of vegans and so on. Vitamin D deficiency, that is, living in areas with a low level of insulation, these are the northern regions, for example, of our country, and so on. Indications for the examination, which in this case you and I can exhibit an orthopedic traumatologist. These are traumatic fractures of the vertebrae, wrist or proximal femur, that is, fractures that the patient clearly states in the anamnesis that he does not remember a serious injury. A decrease in growth, the so-called curling, yes, that is, a sharp increase in thoracic kyphosis. For the first time, acute pain in the back or thoracic in the rest of it in patients over 60 years of age. Of course, here you can immediately remember about osteochondrosis, but with all the desire we must forget that sometimes in parallel with this there is a degenerative dystrophic process not only in cartilage, but also in bone tissue. Strategy for the treatment of osteoporosis. It is recommended to start treatment from the age of 65 in a patient with a history of fractures. Younger people who do not have fractures are recommended by changes in bone mineral density and assessment of risk factors in the plan that you and I have now sorted out on the previous 3 piles. If the patient's parents had fractures and with minimal trauma, yes, that is, there were fractures, probably, which a person can now retrospectively associate with the osteoporosis that the parents have. That is, specific therapy should be started when the T criterion is reduced to the figures of osteopenia, that is, without waiting for the development of osteoporosis, that is, with figures less than -1. When taking glucocorticoids with those criteria that are reduced to less than 2, not 2.5, but 2, that is, we are still in the stage of osteopenia, it already makes sense to start taking preventive medications that involve the treatment of osteoporosis. In all other cases, when we have osteoporosis confirmed by densitometric methods, that is, with a T criterion of less than 2.5, it definitely makes sense to prescribe an osteoporosis medication to the patient. What drugs are used for osteoporosis? Let's start with the most common, with the drug you know, which is definitely included in all treatment regimens for osteoporosis. Currently, no therapeutic program for the treatment of osteoporosis is planned without the appointment of calcium salts. On the other hand, you should clearly assess that simply using calcium salts, osteoporosis is not something that cannot be cured, and it's even somehow ridiculous to say that you can somehow cure the disease with this. To correct the concentration of calcium in the blood, yes, but not to cure the disease. The preferred form of the chemical form of calcium salts for the treatment of osteoporosis is the most easily absorbed form of calcium citrate in the body. In order for calcium to really be absorbed in our body, if you remember from the biochemistry course for the first course, we need vitamin D. It plays an important role in the absorption of calcium in the intestine, and the preferred form of vitamin D, in this case it is vitamin D3, that is, it is in the form of whole calcium feryl vitamin, that is, it is vitamin D3, we have the most effective absorption of calcium. That is, it may seem that the most then qualitative form for the absorption of calcium is calcium citrate in combination with vitamin D3. But there are such forms, they are presented on the market. The most famous of them is calcimin. Here, even I have presented to you the composition of calcimin, which includes an additional set of trace elements. The drug costs quite moderate money, it makes sense to prescribe it. The scheme is also presented here at the wedding. Don't just get hung up on calcimine. A fairly large volume of calcium preparations with vitamin D3 is now offered by our pharmaceutical industry. Yes, here the most widely encountered of them is calcium D-trinicomed, alpha-dol calcium. Everyone has their own charm. For example, alpha-dol is convenient because it is taken once a day. A large tablet, swallowed once and that's it. Calcium D-trinicomed, it is presented in a rather interesting form. It is a chewable tablet with a taste. Yes, that is, not only do you treat, it is also pleasant for you to chew such gum. Well, here's another bit rum ring presented with a fairly expensive, but high-quality imported drug. In most cases, almost all drugs in this group are licensed not as medicines, but as biologically active additives. This allows you to bypass many systemic obstacles for promotion to the market. I don't know how much this may affect the quality of the drug, but at the moment I personally mainly prescribe calcimine. Diet. Also, do not forget that in addition to the artificial moment of calcium absorption, yes, you and I actually have a banal food that can abundantly contain calcium. Here, pay attention. Here on this plate the calcium content in them is presented at the rate of 100 grams of products, and look, milk is not in a winning position. You and I have always been used to milk being a source of calcium, right? Yes? Well, pay attention, fish can often give us more voluminous indicators for calcium. Oddly enough, the greens, mind you, are more than milk. Seeds and nuts give a high-quality set of calcium. Yes, please note that halva contains quite a serious amount of calcium. Sesame, such a small nut, is the leader in calcium content. The option of dairy products is ideally cheeses. Here are the hard cheeses she is with you. In this case, this product has a very high concentration of calcium. On this slide, we turn to another group of drugs that is included in the treatment programs for the treatment of osteoporosis. The first thing we talked about was that calcium supplements with vitamin D are a mandatory component. Here this group of drugs is called anti-resorptive drugs and, as this name already implies, you understand that these drugs prevent the destruction of bone matter and the leaching out of it, the so-called native calcium itself, that is, the resorption of calcium from bone tissue. Here is one of the groups of such drugs are the so-called calcitonin. Basically, these are artificially synthesized hormones based on calcitonin, and calcitonin is not human, but calcitonin in salmon. It is much more effective than human calcitonin. The pioneer in the pharmaceutical market of these drugs was the company Novartis, which has long since started making a drug called Myocalcic. Here it is presented to us on the left. One of the first generics that appeared was a drug, by the way, also a fairly well-known Swiss company. Together with the Canadians, they made Alastine. That is, in this case, it is somehow strange to talk about the basis of generics, which is produced in countries with their own very well-known pharmaceutical industry. That is, it is not produced in India, yes, not in China, but in our case it is produced in Switzerland and Canada. But this is essentially the second generation of calcitonins that has appeared. This is Alastine. The drug is available on our market, it is registered in our country and is actively sold. The form of use of this drug is very unusual. It is used in the form of a nasal spray. Myocalcic is also available in a parenteral form, yes, that is, it can be pricked, but it is the very form of nasal spray that is very convenient for patients. That is, imagine that your daily dose is 200 international units, that is, 1 zilch. Here is such a bottle, it is designed for 14 of these same puffs. 2 bottles of no power is a monthly norm. Yes, that is, there are at least 14 doses in one bottle, but usually 15 there. One is squeezed out of it by patients. That is, you bring it to your nose in the morning, puffed, inhaled, that's it, you got a dose of the drug. Accordingly, 2 vials, a monthly course. Usually, the duration of course therapy with these drugs is about 3 months, followed by a 3-month break. The courses are repeated. As you understand, the disease called osteoporosis is a chronic process that does not imply the possibility that we will cure the person. A person, in most cases, will be forced to take medications for life that will allow his bones not to break down so quickly, not to lose mineral density so quickly. It is definitely necessary to prescribe calcium preparations with active metabolites of vitamin D in parallel with the appointment of Myocalcic. I will repeat again, I have already talked about this. The Russian equivalent of Upren has recently appeared on the market. Note that in this case, as for the price structure, it is not a fact that it costs less than imported analogues are presented, but there is a place, and it is already pleasing that our pharmaceutical industry has also learned to do such a high-tech thing as synthesized salmon calcitonin hormones. The next group of anti-resorptive drugs are the so-called bisphosphonate drugs. That is, as you understand, instead of calcitonin preparations, it is possible to prescribe these same drugs, biphosphonates, as an antilysative agent. There are several generations of biphosphonates in different countries, and they are licensed in different volumes. In some countries with a conservative approach to licensing modern medicines, the first generation has remained. For example, many European countries are still working on ephedronate and are very jealous of it and are suspicious of modern drugs. We have a fairly progressive state and we have allowed even the most modern third-generation drugs from the series without phosphonates. We have actively allowed cylindrinates, and we will now try to talk about representatives of different generations of these funds. They are really all effective, they just have certain specific features. Here you pay attention, take a closer look at these piles. Various representatives are represented here, and at the same time there are some indications of methods, dosage, course doses of their use, of these drugs. Here is one of the features. What is the difference between first-generation drugs and subsequent drugs? It's in their effectiveness. According to the anti-blocking activity without phosphonates, they can be arranged in order of increasing effectiveness, and the difference between the first and the last of the representatives of this group, the last one is faladronate, is 5 orders of magnitude, that is, 10,000 times. This suggests that the dose can definitely be reduced, and the drug with a small dose will be as effective as 10,000 times a large dose of the first drug. Well, let's pay attention to the options that are here. Look, we have quite actively promoted Fosamax and Fasavance on the benefit market, and the packaging option assumes exactly the multiplicity of their use if, as we have already said, the drugs of the first initial groups, yes, to which Bonifos can be attributed, had to be taken quite often. Then in this case the drug is already the second generations of Fosamax. Fasavance was used once a week, yes, that is, for tablets for a month. Here is such a monthly dose presented here. A more perfect option, and probably at the moment the drug of choice that it makes sense to recommend to people, is a drug of the latest generation. A drug containing zavendronic acid is Avasta. Here is Avasta, which is made by the same concern on the ward, with which he was a pioneer in the creation of drugs for osteoporosis. Quite serious, one of the largest pharmaceutical companies in the world. This drug Aquasta has a very original method of application among the preparations of the phosphate-free series. It is used paratherally, intravenously, drip, and it has quite an original effect, for example, a course appointment. It is used once a year, mind you. Price. The price, yes, is appropriate, not the smallest, but you understand yourself, this is the price for an annual dose of the drug, so in essence it is also quite economically advantageous. How is it used? Here is a 5 mg vial diluted in saline and drip injected into the patient. In this case, the patient should be in a day hospital, that is, well, most often private medical institutions are engaged in this treatment, although the moment of its use in state medicine is not excluded. So, why the day hospital? The introduction of a drip solution involves a fairly long stay, that is, it is not introduced in 3 minutes, but still the fact must be dug at least 20 minutes. Plus, he has a very interesting, I can't call it a side effect, a very interesting feature. Against the background of the drug administration, the patient begins to feel a sense of prodroma, that is, he may have a little fever, his temperature may rise briefly, he may have a short-term general malaise, headaches pass literally immediately after 2-3 hours. That is, for these 2 or 3 hours, the character should probably stay in a medical institution. How the company Advartis interestingly approached this very side effect. It does not happen to everyone, but it is quite common. And if we talk to the patient, as at least the advertising representatives from Novartis stipulated, then the feeling of this prodroma may indicate that the drug is genuine and the drug is guaranteed to work effectively. You yourself know that, probably, this is a problem not only for our domestic market, but sometimes we have falsified drugs. So, Aquasta. A single intravenous drip once a year is enough for a qualitative effect. Fasting in parallel with this, of course, taking a course of vitamin D and calcium preparations. Another group of antiresorptive drugs includes quite interesting drugs that are prescribed mainly by gynecologists and are prescribed for secondary osteoporosis against the background of, let's say, what is called menopausal syndrome in gynecology. That is, in order to prevent osteoporosis, hormonal compensation is provided to women with low bone mineral density. This treatment can be started up to 10 years after the onset of menopause and should last as long as possible, but not less than 5 years of admission. There is quite a wide variety of drugs, plus, depending on which sex hormones are involved in them, drugs with hormonal replacement of estrogen are isolated. Here they are presented in large volume on this slide. There is hormonal replacement of progesterone, yes, there is also a large volume of various drugs. Combined estrogen and progesterone preparations are also presented here. Again, you probably should have studied this group of drugs to a greater extent on the gynecology cycle. So, who will be an obstetrician gynecologist? Think about it. That is, if there is a uterus, estrogens are taken daily. The form of resection is very similar to the resection of hormonal contraceptive drugs. In addition, monthly courses of progestogens are required and preferably progestogens should be used in parallel with estrogen preparations for 12 days. Women who have undergone uterine extirpation should only be prescribed estrogen. To a similar group, as it was on the previous slide, antiresorptive drugs include selective modulators of estrogen receptors. That is, in essence, it is not a hormonal drug, it is a drug that affects estrogen receptors. In our country, it has not been registered yet. Yes, it introduces the name, this is Maxifen. Well, here he is registered with the neighboring head of state of Ukraine. There is a form of taking a Ukrainian drug, which, well, sometimes they used to bring actively from there. Now, unfortunately, it is probably a big difficulty. Drugs of this group bind to estrogen receptors, while in some tissues they act as agonists, and in some as antagonists of estrogen receptors. But from osteoporosis against the background of menopause, they work as a high-quality antiresorptive drug. Another direction of treatment for osteoporosis is not antiresorptive drugs, but on the contrary drugs that promote bone formation stimulation. These are so-called anabolic drugs. Here in the world practice, the treatment of osteoporosis has developed two schools, European and American. But, as you understand, the countries of Southeast Asia, the countries of Africa are deprived of such, perhaps, such a problem as osteoporosis. That is, osteoporosis is the lot of the Nordic countries, the lot of countries in which we have quite a little solar insolation, in which the Caucasian races live and which have big problems with natural vitamin D, that is, natural absorption, calcium intake. So the Americans on that continent took the path of developing anabolic drugs based on parathyroid hormones. Well, there is such a form of resection, very much resembles the form of taking insulin, a pen and daily injections of tirzepatide. Here the drug is called Forteo, this is its commercial name. At the moment, this is the most effective way to restore the quality of the bone. The effect of parathyroid hormone is due to increased bone remodeling, and with intermittent periodic use, the anabolic effect prevails, which leads to an increase in bone mass, and quite actively, as the creators say. In 2 years it is possible to increase the mineral density of the speed by 13%. The method itself is very expensive. The original Forteo drug on the American market costs such a pen with a monthly intake costs about 5,000 American dollars. There are generics. China has very actively picked up this technology, and here is a generic, that is, a Chinese pen, presented from below. Well, her price is half as much, but also not a small amount of $2,500 per month. Combination therapy, drugs that have an effect in the treatment of osteoporosis. In this case, the effect is proven, but the mechanism is quite poorly understood and the drugs, oddly enough, are quite old. Yes, these are aspartate hydroxyapatite complexes. Yes, the composition includes mineral components calcium, phosphorus, bone metabolic proteins. They have a double effect on the bone, both anabolic, that is, activation of osteoblasts, and anticatabolic, inhibition of osteoclast activity, as an independent treatment of osteoporosis are quite active, have been used for a long time, but not to say that they are as effective as drugs of the antiresactive group or, especially, as drugs that are used in the USA, that is, parathyroid hormone preparations. A fairly well-known drug, which, in my opinion, is held by the French firm Pierre Fabre, is osteogenin. It has been on the market for a long time. I also remember it in the 90s, as one of the tools that was actively used for slow consolidation of fractures. Osteogenin takes 1, 2, 3, or 4 tablets twice a day and for quite a long time, more than 6 months. It is prescribed in combination with estrogens or with calcitonin, that is, it can be actively combined with biphosphonates, with vitamin D, that is, in essence, a fairly high-quality supplement, as, let's say, a means of enhancing treatment with traditional drugs for osteoporosis. Another interesting group of the drug is a fairly experimental drug based on strontium. This is strontium renylate, which is supplied by Seria on the territory of our country. This is the so-called Bivolo. The drug is very peculiar. It is used in European countries, but, for example, in the same USA, it has not been licensed by the FDA. The FDA is a pound association. It is an American regulator in their market, well, where something similar to our Rospotrobnada, which licenses food and medicines. So, Stronza drugs are not allowed in the United States. Oddly enough, they are quite actively used in our country. I have tried and, to be honest, for some reason I will not find a pronounced effect on this drug. Although it is probably not worth hoping for a pronounced effect from drugs for the treatment of osteoporosis. The drugs in this case work out the same function as the drugs of basic therapy which we considered in the last lecture. Their main goal is to stop or slow down the process. Well, in this case, the recommended daily dose of white hair is 2 grams. That is, it is the contents of 1 sachet of 1 sachet. Yes, that is, the bag dissolves and is taken inside. It is recommended to take it before going to bed, not earlier than 2 hours after eating. But it is taken into account that the results of long-term use are still unknown. This is one of the most recent, say, inventions in the pharmaceutical market for the treatment of osteoporosis. With this, let me finish our lecture. The lecture was not very long, but the lavids in the picus of the previous one, which took 2 hours, we just fit into the normal, say, 2 or 2 pairs for 2 lectures. Have a good day, goodbye.